Good afternoon, everybody. It's really an honor and a privilege, actually, for me to be here. I was the organizing secretary for SITSCon 2024 in Hyderabad, and I must say this year is bigger, grander, and better. Thanks to Rajiv Soman sir, Vasant sir, and Umang, and everybody else in the organizing committee for having me here. So, I think I would like to request on stage the panelists, Dr. George M. Verghese sir, Dr. Divya Joshi, Dr. Mala Kaneria ma'am, and Dr. Somendranath Haldar. So in the interest of time, I would sincerely like to request the panelists to keep their responses crisp and precise, and we will start. So the topic is Make in India. So it was a little puzzling when we first got this topic, but both of us have taken it to mean diseases which are associated more strongly or moderately at least with India. So I'll begin with the first case. This is a 62-year-old female from Kadapa in Andhra Pradesh. She's a homemaker by occupation, and there was no significant comorbidities. The only relevant past medical history was dental capping. She presented actually in January, she started in January this year to have intermittent retrosternal chest pain, and on evaluation was found to have a cystic lesion in the right lower lobe, which measured 4.2 into 2.8 into 5.4 centimeters, and was labeled to be a benign pulmonary lesion. This chest pain actually subsided with analgesics. And you can see that here in the image. However, the chest pain did continue to occur over the next 3 months. So this is probably February to April this year. There was a little increase in the size of the lesion. It was lobulated and cystic, and there was consideration also that this could be a neoplastic lesion. She was advised further evaluation for the same, and you can see that there. And then over the next month, this is this summer, in May, she started to have high-grade fever with chills and continuous chest pain. And I'm not exactly sure why, but if it was identified or not, but the CAT scan at that time showed aneurysmal dilation at the lateral wall of the aortic arch. You can see that here, right? And it's also reflected in the coronal section. But as per the previous plan, she did undergo a bronchoscopy, which was really not conclusive. And she also underwent a CT iotogram, which was suggestive of this aneurysm that you can see here. Okay. So then she was referred to our center for a thoracic endovascular aortic repair. So this is a summary. It is a 62-year-old female with no known comorbidities, chronic chest pain for about 5 to 6 months, recent fevers, and imaging revealed an aortic arch aneurysm. It also identified a chronic lung lesion in the right lower lobe, which was very likely benign. And I'll further add at this stage, we had all this information with us, and I spoke to my radiologist in detail, and when they looked at the scan, they said, this is most likely an infected aneurysm. It is very unlikely to be of any other cause like atherosclerosis, but this is most likely we're dealing with an infected or a mycotic aneurysm. So I'll stop here, and I would request the panelists to give in their input. Maybe we can start with George sir. And I would also like to add, actually, we have a 5th panelist, which is AI. Okay, so I think after this round of questioning, I'll just show what, I fed in all of this information. We used ChatGPT, and I fed in the information to ChatGPT, and we'll see what ChatGPT says after the panelists give their input.
So just to come back to the case, this
yes,
62-year-old lady who comes with a cystic lesion and eventually was diagnosed to have aneurysm in the aorta, and she is also febrile.
Right, sir.
Now, from what I can make out from the images is that it looks like saccular aneurysm.
Yes,
so
sir.
whenever you talk about aneurysm in the aorta, you look at are we dealing with saccular aneurysm, which means there is a weakening of the wall and then there's an outpouching, which is usually an infective process. The other aneurysm, the fusiform aneurysm, you know that it is congenital and there are factors which are. So to me, looking at the picture and the saccular aneurysm in this lady with fever, I would, my probability for a mycotic aneurysm is very high. And as you know, mycotic is a misnomer. It is not fungus. So in this kind of setting, not that fungus cannot cause mycotic aneurysm, in this setting, in a 62-year-old lady, this syndrome is most commonly associated with atherosclerotic disease. So the atherosclerotic plaque dislodges and an organism seeds there and causes the aneurysm. And the most common, the infection what you see with this is non-typhoidal salmonella. I mean, so in terms of my thinking, this would be my first differential when I look at this problem. How would I solve this? I mean, it is easy to diagnose because whenever you have an endovascular infection, if the patient is not on antibiotic, you will be able to culture the organism. So I would certainly do adequate cultures to establish the diagnosis. And if I'm not able to establish the etiology, then I would move on to the other causes.
So I would just like to add that this patient, over the course of the 5 to 6 months, she received a bunch of antibiotics, cefoperazone, sulbactam, piperacillin, tazobactam, azithromycin, doxycycline, ferropenem. So she's been heavily antibiotic exposed. Yeah, anything?
Yeah, correct. I think I agree with George sir. And one more thing that we have is the patient, the lady, 62-year-old lady, was absolutely fine when she was evaluated with just a mild sternal pain, and she did not have anything pertaining to the lung. There was just a cystic lesion sitting there, and then she developed. So we don't know if this is a very chronic process which is brewing into the background, or this is something which has happened recently. Also, she's undergone some dental procedures which has happened. So are we looking at some sort of some streptococci or something which has gone from that area and gotten and struck to the aorta? As rightly pointed out, we're looking at a saccular aneurysms. So my diagnosis would be bacterial most commonly, as sir pointed out, because she's come with fever and chills. The other possibility is it's a very chronic indolent thing going around, and maybe there is something like an NTM sitting there in the lung, and then which is gone and maybe gone towards this. This is one more thought process. And yeah, over to the other panelists as well. And yes, as sir pointed out, it's a misnomer. Mycotic does not mean fungi, but yes, does not mean fungi cannot cause. You can have invasive fungal infections also giving rise to mycotic aneurysms. Thank you.
So I totally agree. There's a saccular aneurysm, and the patient has a history of dental capping earlier. So there is a possibility of dislodgement of some organism from there. But NTS is common in immunocompromised individuals. So is
she's
she
above 50,
immunocompromised?
which is itself a risk factor for
62.
Yeah, invasive.
But anything else besides
non-typhoidal
this?
Sorry.
Anything else besides this?
Besides the age, there's nothing else. No.
And that cyst is definitely benign.
Yeah, I again went to the radiologist with the films and everything, and it was very clear a bronchogenic cyst.
Yeah, so since this is not an antibiotic naive patient, I guess we are going to have a problem treating the patient. But yeah, NTS is a possibility.
So I completely agree with sir, ma'am. The issue is that we have to address the lung lesions also.
Right.
So if I combine both lung, I should think of one etiology which will be able to explain both the lung pathology along with that saccular aneurysm. So maybe some bacteria which may be responsible for these two things, and fungal chances is very less. As sir already mentioned, it's usually it is not due to fungus, but I will think of that organism which is able to explain both these two pathology.
Right. So anyway, I'll just show you what ChatGPT said, and like what sir had said, Salmonella was really high up on the cards, classically linked to infected aneurysms in Asia. And also mentioned even gram-negative rods. And there was a paper by Dr. Akshata about aneurysms, I think when she was in Jodhpur, which talked about Pseudomonas as one particular case, but then syphilis and so on. Okay? So cultures were negative. We sent 3 sets of blood cultures, and labs were really unremarkable. And because the cultures were negative, we also did sequencing, which was unfortunately negative as well. And there were no vegetations on the transthoracic echocardiogram. Testing for syphilis, including VDRL and TPHA, were both negative. And one thought was just to give a ceftriaxone with a glycopeptide, but I was just a little worried about some cases of Pseudomonas, so we just gave her a little broader coverage with meropenem. At this time, actually my preference was not to start antibiotics, but the cardiac surgeon was really not in favor of that. And he was not very convinced it was an infected aneurysm. So we proceeded to get a PET CT, which kind of showed us a very similar picture. It just confirmed what we already knew. Now, convincing a cardiac surgeon to go in and get a biopsy at this stage, when the patient is hectically febrile, is not the easiest thing in the world. So the plan was to discharge her on antibiotics, and once the fever trended down, the plan was to go in and get her operated. So she actually worsened. There was an increase in the size of the aneurysm, as you can see here, and so they finally went in, and they found a large mycotic aneurysm from the distal aortic arch to the proximal descending thoracic aorta, thinned out and about to rupture, plenty of clots and necrotic layers of the aorta. You can see the aneurysm right there in the opened up aorta, and they put in a polyester graft end to end, anastomosed it to the proximally to the aortic arch and distally to the descending thoracic aorta. Okay? So this is what was put in there, and you can see the graft there. And now, as they say in ID, tissue is the issue. We had tissue, now let's find out what the issue is. Unfortunately, we still didn't have a diagnosis. Gram stain was negative, cultures were sterile, fungal stain, AFB stain negative, expert MTB RIF ultra not detected, and I went to the pathologist, I kept calling her. She was saying, I'm sorry, I can't help you. All I can see is acute inflammation. So you can see a lot of hemorrhage, fibrinode necrosis, some cholesterol clefts, and just a lot of neutrophils, okay? So dense acute inflammation, AFB stain negative, GMS negative, so dense acute inflammation. And just before I reveal what we did further, this is where we were stuck. So we have an infected aortic aneurysm with a patient who's been operated, and they got a good chunk of tissue. And there was a graft there, and now the surgery went off very well. She was extubated on POD1, she was transferred out of the CTOT on the 2nd or 3rd post-operative day. She was doing very well, the cardiac surgeon was very happy. He said, I'm going to send her home, you just tell me now it's your case. So that was where we were, that's where we are, sir. So.
What I would do at this point is, I don't think my prioritization of the differential diagnosis changes. I still think that it is non-typhoidal salmonella causing the mycotic aneurysm in the aorta, because the syphilis and all the other differentials, the features are very different.
Yes, sir.
Very different. So what will I do? I would probably start off with the 16S RNA gene amplification and sequencing, or maybe even metagenomic sequencing.
So I'll just go ahead and say that we did that, sir. And what did you think, if you could pick one organism that you think that was revealed in that, what would you choose?
I would go for non-typhoidal salmonella.
Okay. Okay.
I think you can reveal the.
Okay, sure. So anyway, we'll see what ChatGPT said, and it kind of said the same thing. What to do diagnostically, broad molecular testing, 16S ribosomal RNA PCR, and ITS. But anyway, I'll just show you what it said. It said Brucella abortus. So, and then I remember asking her, do you drink unpasteurized milk? She said no. But you asked her, do you have dogs or cats at home? She said no. But she did have cattle at home, and she used to drink Junnu, which is the first milk of the calf. And she was there with her son post-op, so she wasn't very clear in whether she helped in the delivery of the calf or not. but this was serologically also positive. We didn't do a SAT, we just did an ELISA. And this patient was started on rifampicin, doxycycline, and gentamicin. Just for want of time, I'll say that she did develop some kind of cholestatic hepatitis with rifampicin, acute kidney injury with gentamicin, so we have to modify her regimen a little bit. And more recently, she's refusing to take IV injections. She's completed 6 weeks of treatment and is clinically well. So I guess I will stop here and hand it over to Dr. Nitin, and if there are any other inputs from
So brucella just affect the aortic valve very, very commonly.
Yes.
But this sort of presentation is kind of atypical. I mean,
Yeah.
we wouldn't have really thought about it. But no other backache or anything else.
Right.
And no myocardial abscess also, because brucella causes abscesses in 43% of the cases and involvement of the aortic valve. So this is a bit atypical. I think even AI couldn't help you, right?
Yeah, so the
I think the
brucella,
exposure history was a little clinching, but unfortunately, we only got that in retrospect when we specifically asked.
yeah, so probably brucella in slightly damaged valve, we know that it causes endocarditis.
Right, sir,
So in the same way, that actually occurs with the bacteremia.
Yes.
So if you look at all the, the series
Yes, I'm
where
just
you
showing
have
that,
the
yes, sir.
mycotic aneurysm,
Right.
it actually is, by probability, it is non-typhoidal salmonella. Can brucella cause this? Yeah, you've really shown that probably this is brucella itself. So I think it is a great case. The brucella, probably a bacteremia seeding
Yes,
onto
sir.
an aortic plaque.
Pre-existing.
Yeah.
So how common it is for brucella to producing this kind of lung lesions, which was you presented there?
Sorry, in these kind. Oh, actually, the lung lesion was probably a red herring.
Okay.
That was
issue.
my conclusion, because I actually sat down with the radiologist, showed them all these scans. They were like, no, this is a bronchogenic cyst. Don't worry about it. And when there was also on the PET, for what it's worth, there wasn't really anything writing up. So even the PET excluded any kind of a lung infection or malignancy, whatever it was.
So we are 7.5 minutes behind. We plan to present 4 cases. Thankfully, my cases are very simple and short. I've just kept summary slides. The other thing is that about the theme, what I understood also was that the idea was to take the help of local data to kind of answer the questions that are local to us. So no IDSA or European guidelines coming to help us here. I have slightly dramatized the cases a little bit because in general people who practice with these diseases, some of these things are very organic to them, but just for the sake of the audience here, but I'm sure the panelists will be aware of the simple diagnosis. So this is a patient who has come to us, a 32-year-old male patient in January. He has come with a high-grade fever for 4 days. He returned from a visit to a coffee plantation in Chikmagaluru. It's a district in Karnataka. The patient had severe myalgia. There was retroorbital headache. 3 or 4 days down the line, he had some melena as well. He was drowsy but arousable. His APTT was increased. The PT was normal. You see, clinically, he has some conjunctival erythema. There is some palatal petechiae. You see this diffuse blanchable rash. You can see the impression of my fingers on the patient. You see that there is a little bit of increase in the hematocrit. There is leukopenia. The TLC is 800. Platelet count is very low at 5,000. The CRP is not elevated. AST, ALT is more than probably 20 times the upper limit of normal. So I have focused questions to the esteemed panelists. So what investigations will you send?
So this is looking like a picture of a community-acquired febrile illness with localization to maybe travel history to Chikmagalur, and the patient is presented with some sort of an ictro-hemorrhagic kind of a fever picture. So I think we need to, and this is which day of the fever
this
presentation?
Is day 4. There is no jaundice.
There is no jaundice, right? So no jaundice, right? So a hemorrhagic kind of a picture. So definitely dengue, blood cultures. Antibodies may be later in the stage, not at this point of time. We can even send for a rickettsial PCR, and not to miss out on the maybe the picture that you showed before starting the KFD and with pelletial this thing involved.
Definitely, all of them are great possibilities.
Yeah.
Which season is this?
This is January.
So it's a dry season or it's a dry season?
It's a dry season in
Karnataka.
Karnataka, yes.
So IgM leptospira and IgM scrub typhus would definitely come positive in the second week. This is like a tropical fever. He's got pancytopenia, he's got severe myalgia, he's got transaminitis, which is higher. So blood culture and NS1 antigen for dengue, but there are other things also which I would consider in this patient, probably a KFD also, which is more common in Karnataka. So E definitely not, but yes, in the first week NS1 and IgM scrub typhus I would think of sending, if these are the options.
Right, agree with all your points. Sir.
Yeah, just to add on to that, I would probably send all of those to rule out that, because which is much more common
Right.
when you look at a hemorrhagic fever, so to
Right.
say. But I think because you are presenting this, most likely it's going to be KFD.
Right. So, I said
Why did you put IgM leptospira? Why didn't you put leptospira PCR first 4 days?
I think there is no option to question the questions. So, these are the questions, you have to choose the answer. So, the thing with leptospira is that we know that the serology comes positive by second week. In some cases, it can come as early as 4 to 5 days. The other thing with leptospira is that leptospira usually has bland cholestasis. So bilirubin is more elevated, AST-ALT of 800, 900 is probably not there. So this option was anyways not there. For anybody who manages patients with dengue, this looks very similar to dengue. And the thing is that in our region, in 5 states and at least 16 districts of South India, dengue is very, very similar to KFD. There are some peculiar things that I want to discuss, but I'll go to the next step.
One point, conjunctivitis is not common with dengue. The patient was having conjunctivitis.
So there was a conjunctival erythema, which
Yeah.
can happen with dengue, but it is, so I'll show you the next slide.
Yeah, it is.
This is the ChatGPT's answer, which agrees with what most of you are saying, is send all of them simultaneously. Some of them are bacterial diseases which might require a treatment, so it's a good idea to at least rule them out. I agree that, in the first week, better to do antigen and PCR-based tests, but scrub lepto starts to come by day 4. So in settings where these are not available, it might be a good idea to do them anyways. The one thing that Madam was telling about the season is very, very important. So this chart on the top, I have made for our region. So in our region, what happens is that July is the monsoon season. With rain comes leptospirosis. With rain comes a lot of mosquito-borne diseases. When the temperature starts to go down, but the moisture is still high, 25 to 30 degrees Celsius, ideal temperature for the mite of scrub typhus. So we see scrub typhus September, October. A lot of South Indian states have a similar pattern. In the drier season, when the ticks do not get washed away easily, people venture into forests or nearby regions to collect firewoods. That is the time when the tick-borne diseases are active. So the spotted fever and KFD. So the patient has come in January, so very likely there is a good possibility of a tick-borne disease here. The other thing I've shown a chart where I've tried to compare these features. These are not absolute, but kind of gives you a gross idea. So if there is parietal petechiae, it can happen with dengue, KFD. Conjunctival suffusion is described with leptospirosis, but erythema more with KFD, but not uncommon in dengue as well. Leukopenia suggests a viral illness or a bone marrow suppression due to enteric fever. Thrombocytopenia is not really helpful. Maybe the degree of thrombocytopenia, 5,000, 6,000 is something which you see more with viral illnesses like dengue or maybe a KFD. A raised CRP might not be that helpful, but a low CRP, at least in dengue, KFD, it helps in trying to rule out scrub, lepto to some extent. Coagulopathy is the interesting thing, I'll come to it. So the patient presented again after 8 days, after he was managed conservatively, some platelet transfusions, he did fairly well, discharged. He has come with fever, headache, gait disturbances, visual blurring, TLC is 13,000, rest of the parameters are normal. So by this time, we have sent a test for KFD. Again, like I said, I have dramatized a little bit. We have sent a test for KFD and we are awaiting the results. And just to discuss what will be the possible differentials and will you start any antibiotics at this stage or steroids at this stage?
Even though the differential diagnosis, we are sure and we are waiting for the reports, we are looking at some sort of a meningoencephalitis kind of a syndrome happening over here. The differential diagnosis, I would definitely start the patient at least on ceftriaxone toxi plus acyclovir till I know what is happening. Maybe.
Right.
So neurological symptoms are common in the second week in KFD. So it's quite likely this is KFD, yet definitely some doxy-based regimen I would probably start without waiting for the report.
Right.
Probably, I mean, there is a neurological involvement now, given the fact that there was hemorrhagic manifestations initially, the first phase, and then the neurological manifestations obviously means that the probability for KFD goes up even higher.
Right.
So what will I do now? I wouldn't give empiric therapy.
Right.
If I can, I would probably, I mean, if the definitive test is not back,
Right.
I would probably do CSF analysis under platelet cover,
Right.
making sure that, you know, the...
Right. By this time, sir, platelet has normalized and TLC from leukopenia has gone into leukocytosis.
Sure.
I think everybody knows the diagnosis KFD, and I was trying to just kind of build how it happens. So in places where we manage a lot of KFD patients, second week is not very uncommon, at least 20-30% of the patients likely to be underreported. So when these patients come, they will come to you with features of meningitis, cerebralitis, and at this point of time, with our experience, we just don't do anything. But anyways, for the sake of discussion, ChatGPT says, give everything. So if you are working in a region which is non-endemic to KFD, let's say Mumbai and somebody travels from Chikmagalur, I'm sure you will not be comfortable with not treating a patient with meningoencephalitis. So here, trying to cover everything that is possible is not a bad idea. Also, it is known that sometimes ticks transmit two diseases at the same time. So it is possible, but in my region, in a KFD endemic region, I will not treat this patient. So these are the possibilities. I think everybody is aware of that. So we did an MRI, which is normal. The idea to show this is that sometimes MRI can be normal in second phase of KFD. We did a PET. Again, this is not routine, but the idea was that in tick-borne encephalitis, it has been seen in the European cohort that sometimes the MRI can be normal, but there is functional disturbances with cerebellum. So it can be so there can be increased metabolism in cerebellum, which can be shown in a brain PET. It costs us cheaper to do a brain PET. Anyways, we did it in one case. It's not a routine again. CSF, again, we don't do it routinely. It just showed some leukocytosis, and this is commonly the pattern in KFD. So now we stop doing CSF in patients with KFD when we know. And this patient anyways was found to be KFD. So I will just quickly in 2 minutes summarize our experience with KFD. So KFD usually has first and second phase. First phase is commonly very, very similar to dengue. There is some hemorrhagic manifestations. But first phase can have encephalitis as well, and this encephalitis is directly related to mortality. It is a sort of encephalitis and encephalopathy. Both, there is a lot of hepatic encephalopathy happening in these patients, so this is directly associated with mortality. Second phase, however, has these aseptic meningitis versus cerebralitis type of a picture, and none of these patients die. They recover well. You just have to give them supportive care. In this first phase, from 1950s when the first cases were reported, they frequently see these palatal petechiae and conjunctival erythema. What we have started to do now, started to find a lot of in KFD patients is oral candidiasis because of the severe leukopenia. That can happen with dengue, but not as common and as severe as in KFD. We see a lot of oral candidiasis and sometimes esophageal candidiasis also. Makes it difficult to manage in a patient who has an AST, ALT of 800, 900, but this is something that we have started to see very frequently. CD4, CD8 both are frequently low, the ratio maintained. We have devised a scoring system for KFD just for primary healthcare systems. I'm not going to go into this. Between dengue and KFD, there is a more severe leukopenia, more severe thrombocytopenia, more severe transaminitis in KFD. Isolated APTT is something that we have been noticing a lot, and it actually helps us in diagnosing KFD as well. In short, we did some investigations to find why this is happening, and the probable answer is factor IX deficiency, but I don't have time to explain this further. Neurological manifestations of KFD, like I said, first phase is more likely like an encephalitis, directly related to mortality. Second phase is a cerebralitis. So we have a lot of patients who come with just visual disturbances or gait disturbances. We give them supportive care and they recover. This is transient. As of now, we have not seen long-term neurological deficits with these patients. Diagnostics, so the early phase PCR is very, very helpful. There is no antigen-based test as of now. So till day 14, in general, PCR is frequently positive. And if the patient comes to second phase, if we have a diagnosed KFD in the first phase, we do not need to do any additional investigations. In terms of treatment, it is primarily supportive, just like how you manage dengue. We don't transfuse platelets as much in KFD. And when we are working on predictors of mortality, we found that CT value of the first PCR is directly related with independent predictor of mortality. For the interest of time, I will just invite Venkat for the next case. Thank you. PCR is easily available, sir, in regional labs in Bangalore. It can be done in the NIV. For our region, it is available in our institute. Shimoga has a PCR. You can send it to NIV as well.
Thank you, Nitin. So we'll move on to the third case. This is a short case. So it's a 3-year, 7-month-old female child from rural Telangana. She presented with a slowly progressive swelling over the right shoulder for the past 7 months, which was initially painless and later associated with purulence. And she also reported the parents reported she was having a little bit of a temperature. Multiple courses of antibiotics and also empiric antituberculous therapy without response. The reason why she got ATT, I will allude to further, but the images are quite striking, okay? So this is the first image, okay? I mean, it's the same in just different views. So this is 3-year, 7-month female child, and this swelling has been there for the past 7 months, and it is worsening. There's no improvement with antituberculous therapy. So otherwise, she was clinically well. Mother was tested during pregnancy, and mother was HIV negative. The child was a little underweight with weight at the 25th to 30th percentile. And the ultrasound was not very revealing. It just showed a lesion in the subcutaneous plane. So I would request the panelists for their inputs. I'll just go back to maybe this image.
So any history in terms of any trauma or fall or maybe any exposure to the soil which the patient had probably?
Not specifically that the parents mentioned, no.
And the child is not relatively as sick, and she's been chronically having the swelling which is going up with multiple involvement of this thing.
Yes.
And I think your imaging shows it just involves the skin and soft cutaneous tissue, not beyond further.
Yeah, there wasn't any evidence of the shoulder joint as such being
involvement in this, and it's a chronic progressive.
It didn't look like an arthritis per se, arthritis
per se.
Whatever ultrasound that they did, yeah.
Okay, maybe I would think of some with some exposure of some invasive fungal involvement in terms of demataceous fungi, or maybe chromoblastomycosis or something, or maybe sporotrichosis, something which is grown into, or which is, which is presenting something like this, or maybe some malignancies, if non-infectious thing like carcinoma, squamous cell or something which presents. This is what I would think.
Okay.
Does she have a history of any other skin infection in the past or repeated recurrent skin infections?
No, there's no other signs of, nothing to suggest a primary immunodeficiency.
Any cultures have been performed or any smear or anything?
I'll come to that.
Any other lesion anywhere else in the body? What about the X-ray chest, what the CT chest, CT abdomen, any TB anywhere else in the body?
No, they did an X-ray that was normal, but by and large, there was no other site. She was clinically otherwise, not toxic, low-grade fever, just this was not getting better, parents are vexed. She's got ATT, and she's had a biopsy done also. I'll come to
Parents
that.
are vexed?
No, they are vexed. They are troubled and, not vexed.
Okay.
So anyway.
Any other travel history or pet history or anything else?
No.
So along with these differentials, basically if I will do a imaging, MRI, extent of involvement of the lesions, differentials should obviously include, apart from tuberculosis, NTM, fungal infections, and common fungal infections of that particular area, and atypical bacteria also.
Okay.
So these are the differentials, and I will do biopsy. Before that, I will do a proper imaging to see what is the extent of lesion.
Yeah, just to add on to what has been said, it looks like it is something inoculated.
Right. Yes.
So it's so usually children, when they are playing in the soil, the environmental organisms.
Right.
So those are the ones which are likely to be. The fact that it is multiple areas in the same region points towards a few things. One is nocardia,
right?
Cutaneous inoculation.
Yes,
the other thing, I mean, this is not the usual site, Basidio bolus. usually it is the gluteal region or the, that's more in an adult. In a child, I presume, when they are playing around, you could have this, other than the Basidiobulus and the Demotechius fungi, all that. But in terms of when you have to rank order the differential, I would probably think that the nocardia will come first, followed by non-tuberculous mycobacteria and the fungal infection.
Yes.
And also think of actinomycosis
Yes.
here.
Yeah. So I think, this was exactly our thought process. So, and pretty similarly alluded to by ChatGPT. Lupus vulgaris was another consideration, because if you look at it, you can summarize it like a chronic plaque-like lesion with multiple ulcers and purulence. So cutaneous tuberculosis, but she did not respond to antituberculous therapy. And the reason why antituberculous therapy was given is because she had biopsies done, obviously, which showed granulomatous inflammation with suppuration and giant cell reaction. And that was one. And the other was, one report, and then they, I think she had an FNA first, which showed this. And then the biopsy showed acute suppurative inflammation with abscess formation, foci of palisading, ill-defined epithelioid granulomas with multinucleated Langerhans type of giant cells. And expert MTB, RIF Ultra, all were done on the pus, actually. The biopsy itself wasn't sent for expert, right? Only whatever pus was there, that was somehow sent. So GMS stain, Ziehl-Neelsen stain, routine bacterial cultures, expert on the pus, not on the biopsy, that was negative. So I'll go ahead and, so this is acute suppurative inflammation with abscesses, palisading granulomas with Langerhans type of giant cells, ZN stain negative, no response to ATT. So cutaneous tuberculosis, which something like lupus vulgaris seemed a little unlikely. So any further inputs on what is it that is, that's missing, or any further thoughts? So just to remind you that this biopsy was done elsewhere. So they'd come to us with the biopsy and we were going to get it reviewed.
Yeah, sending again for expert MTB and modified AFB smear, as sir pointed out, to look out for probably nocardia, and also fungal smear and fungal culture had not been done. So I think we should do that as well. So
anyway, we got this, we took the slides to our, blocks and slides to our pathologist, and she saw it. So on low power, there was dense inflammation and foci of necrosis in the dermis and subcutis. And on 20x magnification, you can see, I think for the audience, it will be the bottom left corner, very pinkish material, that is Splendor-Hopley phenomena, and definitely ill-defined epithelioid granulomas that you see, which are circled. And there is, the arrow points to a multinucleated giant cell. And you can see some Splendor-Hopley, which is most prominent in the bottom left of screen for the audience, and for the panelists also. So we know this was first described by Splendor and Hopley. It's due to the deposition of antigen-antibody complexes and debris from host inflammatory cells. And just yesterday, I was looking at the FISF newsletter, and they talked about, I think, one of Raji Somansar's cases. There was a case, but anyway, in this case, it was Splendor-Hopley phenomena with suspicion of actinomyces. And when we spoke to the pathologist first, she was like, whenever I see this, if I have to think bacterial, the first thing I will think is actinomycosis, right? So any further thoughts?
Splendor-Hopley may happen in nocardiosis also.
Yes.
So, yeah.
So when we talk about the, so this is more closer to mycetoma, the eumycotic mycetoma and the actinomycotic mycetoma.
Right, sir.
So in the actinomycotic mycetoma, which is bacterial, nocardia and actinomyces both are very similar, and the gram stain on the microscope also, they will look exactly the same. One is aerobic, the other one is anaerobic. That has to be on the culture. I don't know whether you have a culture, positive culture.
No, sir. It was, I'll reveal the diagnosis. So actually, very luckily, you can see beautifully the GMS stain showing broad aseptate, ribbon-shaped hyphal forms. So this looked like subcutaneous basidiobulomycosis, entomophthalomycosis, and we put this child on itraconazole at 5 mg per kg per dose, and there's some evidence that cotrimoxazole also works, so this child was getting about 8.57 mg per kg per day. You can see it's already improving at 3 weeks, and at 7 weeks, it's nearly gone, right? So that horrible looking lesion has nearly disappeared, and then we gave it for about 12 weeks, and that's where we are. So, and this has been variously reported in literature, and a lot of case reports from India and case series too.
So culture was not possible for this patient.
Actually, she already had the biopsy done.
Done elsewhere.
So we just got a second opinion from our center,
Yeah.
keeping all of this in mind, whatever has been discussed. Yes.
For basidiomycosis, if you get proper sample, the time is very less to get the culture positivity.
Yes.
So most of the times it is helpful.
The whole thing wasn't formal, and
And I know your silver stain had picked up the organism, but otherwise also, I'm surprised they couldn't pick up the broad aseptate fungal hyphae. Usually they will be able to.
I have 3 minutes for the next case, so I'm sorry, I'll just ask for 1 or 2 word answers from the panelists. So this is a patient who has come, a farmer, uncontrolled diabetic, and you see this reverse halo sign. And what are the empiric antimicrobials will you start? So just options A, B, C, D, E.
Only options, right? Nothing
Yeah.
else. And we can't question there. Okay. Yeah.
Farmer,
I would go with C
rural, C.
for now. Maybe I would B. Sorry.
B.
Yeah.
Sir.
Or maybe
No, let the others choose.
E. Sorry. None of the above. Actually, choose
Dr. Haldar, Dr. Kaneria.
So what about the duration of the symptoms? No, nothing.
2 weeks of symptoms, and patient is farmer, diabetic, uncontrolled, HbA1c 11. You see reverse halo sign.
Okay, so amphotericin.
Amphotericin B. So in general, when we see reverse halo sign, we think of mucormycosis, but and this is what ChatGPT also thinks, that you should start amphotericin B. Unfortunately, if you see the list of things that can look like reverse halo is huge, and you know I'm going to just say the diagnosis is melioidosis, and melioidosis can also look like.
I was going to say that. I was going to say that we cannot go by that. So. And this patient is stable. We should not be starting empiric therapy
Absolutely.
for this patient.
Absolutely. So we would have gone for either,
B or C.
Yeah, or none of the above is also
You
an
mentioned
option.
uncontrolled diabetes, so Milliard was very high on the
Yeah.
cards.
Melioid was very high on the cards.
Yeah.
So Mero and Mero plus Vanco, for the first 2 days till you get a definitive
Right.
diagnosis.
So
C
the
was
other
correct.
thing is that in the CT, this is something that we miss. That was in the lower cuts, so radiology did not report it. But what you see is something called as the necklace sign, which is very specific for melioidosis. There is a honeycomb sign also, but there is a study from Thailand where they found that honeycomb sign has poor specificity. It can be seen with others as well. We have seen HVKP patients having honeycombing, but this necklace is more common with melioidosis. Anyways, if you see a reverse halo and liver abscess in an uncontrolled diabetic in an endemic region, you should think of melioidosis. HVKP is a definite next possibility. So blood culture flagged, you see these typical colonies and safety pin appearance. Just this, would you want to screen for other organs, any deep-seated abscesses?
Yeah, primarily liver and spleen, spleen mainly.
Right.
Yeah.
So,
And
liver-
also the bone, if it is a chronic history,
Right, sir.
bone is another area where they.
Absolutely, so liver, spleen are common.
Prostate also, sometimes prostatic abscess may present.
Absolutely. So the point with prostate
Parotid
is that in the Darwin cohort, the thing that is associated with failure and where drainage has absolutely shown benefit is prostate abscesses. The problem with prostate abscesses also, as you will see in this patient, is that prostate abscesses in milioid is peripheral. So your urine PCR or urine culture may be negative, and PSA is also frequently negative. Anyway, so this is a patient, and the common routes that we think for melioidosis is inhalation and inoculation. But ingestion as a route in India, in South India, is very, very important. We have had a lot of patients who come with parotid abscesses or these neck glands. In this patient, the patient also had tonsillitis, and when we swabbed the tonsillitis, the PCR was positive. The well, patient was consuming water from a well, and which was frequently prone to flooding. So that well was also positive for melioidosis. The other route that we should know, and Vellore has published a brilliant paper on melioidosis after a dental outbreak. So melioid can traverse through the nerves as well. So we had some patients, I'm not going into the details, but if you have a sinusitis, through the fifth cranial nerves, it can go up to the brainstem, thalamus, and then along the corticospinal tract, it can cause these microabscesses, which are classically called as the tunnel sign. So these are the papers of some of the patients that we had with tunnel sign. This tunnel sign is classically associated with an allele in the bacteria, and it is frequently found. So in our study, we saw that 5.8% of all melioidosis isolations had this BIM-ABM allele. So problem with this neuromyelioidosis is that blood culture and CSF culture is only 20% positive. So it is very, very important to see these signs on radiology, suspect. The only way you can definitely diagnose these people is brain biopsy in many, many scenarios. Melioidosis is a frequent cause of community-acquired pneumonia as well. This is a scoring system that we built. I don't have time to talk about it. Diagnosis is predominantly radiological signs, clinical signs, very, very important. And then blood culture is what helps you. Serology is not that helpful. There is a rapid test not available in India as of now. Treatment, I'm sure everybody is aware that intensive therapy with ceftazidime and meropenem for 2 to 8 weeks, followed by cotrimoxazole for prolonged duration of 3 to 6 months. Thank you.